The regular and routine generation of aerosols during care provided by dental healthcare providers is what puts us at increased risk of infection as compared to other healthcare providers. The third way is from patient to dentist, and this is what we are most concerned about right now during the COVID-19 pandemic. The Occupational Safety and Health Administration, otherwise known as OSHA, states that in dentistry, using dental turbines, micromotor handpieces, ultrasonic scalers, and air-water syringes are examples of tasks that can generate aerosols. This list is not exhaustive, and other procedures may also generate aerosols. As dental healthcare providers, we must fully understand the chain of infection and how to break the chain of infection, more so now than ever. Here we see an overview of the chain of infection. Starting at the top, we have our infectious agent. Though we are concerned about all infectious agents, today we are focusing on the novel coronavirus that causes COVID-19. This virus must be stored within a reservoir, who is our patient, and must have a portal of exit, which is saliva, and a mode of transmission, in this case, aerosols and droplets. Those aerosols or droplets must enter the route of entry, and those are either the mouth, nose, or eyes, in a host, which is you. And if you do get infected by that aerosol or droplet entering through your mouth, nose, or eyes, you can become infected with the virus and propagate this cycle. So how do we break the chain of infection? Let's start off by talking about our reservoir or our patient. At the time of this recording, regular pre-procedure or point-of-care testing was not available. Therefore, UTSD is relying heavily on screening. When we think about our portal of exit, that is saliva. For this, we are using pre-procedure mouth rinse before the patient is treated. What we know is that this virus lives in saliva. What we also know is that hydrogen peroxide can kill this virus. What we don't have compelling evidence about is that a pre-procedure rinse will reduce the rate of transmission of disease from an infected host. Still, we err on the side of caution, and we are having all of our patients perform pre-procedure mouth rinses with hydrogen peroxide. You can see on this bottle that hydrogen peroxide comes in 3%. Therefore, we're diluting it 50-50 with water so that we create a solution that is 1.5% hydrogen peroxide. One of the challenges with pre-procedure mouth rinses is that even though they kill any virus that may be living in the saliva that's found in the patient's mouth when they first come to the appointment, the salivary gland will continue to produce and exude new saliva into the mouth, and that saliva will contain virus if the patient is infected. Next on the chain of infection is the mode of transmission, which in this case is aerosols and droplets. Droplets are heavier, larger particles which typically settle quickly and within 3 feet of the treatment area. Aerosols, however, are much lighter and travel at least 6 feet away from the treatment area, and in some cases can travel up to 30 feet away from where they're generated. Using a rubber dam significantly minimizes the amount of saliva that is included in the aerosol generation. The use of ultrasonic scalers are currently prohibited under Emergency Rule 108.7 by the TSBDE. However, every time we use an air-water syringe or a high-speed handpiece, we are generating aerosols. And we must use a high-volume evacuation to remove as much aerosol as possible that enters the atmosphere. The use of hand instruments are strongly encouraged whenever possible. In addition, think about using wet and dry cotton pellets in lieu of air-water syringes. While we have heard a lot about the importance of proper use of personal protective equipment or PPE, we must remember that this is only one way to break the chain of infection. Until further notice, UTSD has made a decision to use one protocol for PPE for all oral health care that is being provided. This PPE protocol must be followed by all dental healthcare personnel who are within 6 feet of procedures. This includes the use of a disposable bouffant or surgical cap, shoe covers if they're available, knee-length tie-back or Velcro waterproof gown with cuffs at the wrist, an N95 respirator, and if that's not available or if the provider chooses to use a half-face elastomeric or a powered air purifying respirator, those are also acceptable. Eye and face protection, which typically will include loupes or prescription eyeglasses, and a face shield must be worn on top. Nitrile examination gloves for most procedures, or surgical gloves for surgical procedures. And as usual, all healthcare providers must wear closed-toed, closed-footed, and closed-heeled shoes. There are several types of masks that are used within dentistry. On the upper right-hand corner, we see an example of a cone mask. In the middle image, we see an example of a surgical mask. These are the two most common kinds of masks that are used in dentistry during standard precautions. Right now, during the COVID-19 pandemic, we are under transmission-based precautions, and we are using N95 respirators. An image of an N95 respirator is in the lower right. N95 respirators look quite similar to cone masks. One easy way to distinguish them is that an N95 will have two straps, one that rests on the crown of the head and one that should go at the nape of the neck, whereas a cone mask only has one strap. That's an easy way to tell them apart, but there's a major difference in the way that they protect the wearer. A cone mask is simply a physical barrier, whereas an N95 is well sealed, properly fit tested by a professional, and really protects the respiratory system from small particles. If you do start to feel unwell, it's important for you to go home or stay home and not come into work. In addition, it's important for you to continue self-screening by asking yourself the COVID screening questions and monitoring your own temperature. Finally, on the chain of infection is the use of disinfection, washing hands, changing clothes, socially distancing, and wearing masks. It's important to understand the difference between disinfectant wipes used for patient care and those used for non-patient care. Let's start off with the Optum wipes that we have here. These are a hospital-grade EPA disinfectant wipe that should not be used without appropriate PPE, as they can be toxic to the user. These should be used for patient care situations. Outside of patient care situations, wipes like Clorox wipes or Lysol wipes that are known to kill the coronavirus but that are not hospital-grade disinfectants should be used. Aerosols are light particles and take some time to settle. While we have carefully reviewed the airflow and filtration in all of the clinical areas that are affiliated with UTSD, the CDC has recently released a recommendation to wait a minimum of 15 minutes for aerosols to settle before disinfecting a treatment room. Another way of thinking about infection prevention is the hierarchy of infection prevention. On the left side of the screen, we see elimination, and on the right side of the screen, we see PPE. While we focus very heavily on personal protective equipment, this is actually the lowest rung of the ladder on the hierarchy, whereas elimination is the highest rung of the ladder. So reflecting back on the chain of infection that we just discussed, some examples of elimination are screening. Screening out patients who have symptoms is elimination. Using pre-procedure mouth rinses, rubber dams, high volume evacuation, and what we didn't talk about earlier is that if a rubber dam cannot be used and the patient is in a supine position with pooled saliva, using a saliva ejector is appropriate to minimize the amount of saliva that can be aerosolized. With regard to substitution, if at all possible, to use hand instruments instead of a handpiece, that's strongly encouraged. And like we mentioned before, the use of cotton pellets to replace an air-water syringe is also encouraged. In terms of engineering, our highest aerosol generating procedures will be done in enclosed rooms where we have more controlled air turnover and airflow. Outside of the enclosed rooms, we're only using every other operatory, and in some spaces we're using air scrubbers. With regard to administrative, there's a lot of new rules, policies, and procedures. It's a lot and can feel overwhelming at times, but this is just one aspect of the hierarchy of infection prevention. And then, of course, finally, personal protective equipment. The major changes are the use of a respirator, a face shield, and a disposable cap. So, lots of new rules, regulations, policies, protocols, procedures. It can feel like a lot. But we're in this together and we have to support each other. We have to remember that all of these changes are in place to make sure that we keep ourselves and each other safe. In that regard, we have to make sure that we're monitoring our compliance with these new rules and regulations. This is going to take everybody to pitch in to hold ourselves and each other accountable.